Hello everyone, welcome to EMQ practice session. So, ready?
Hello, ma'am.
Hello, hi. All well?
Yeah,
Yes.
good evening, ma.
Hello,
Good.
ma'am. Good evening.
Good evening.
Correct.
Very good evening.
Hello, ma'am.
Hello. Hello. So everyone ready and well in time. So let's start. It's going to be a totally interactive session, and it's basically we are practicing before the exam. We have already covered all these things. So now in this session, I need volunteers. One of you will be taking up question, and you will read the question yourself, because reading the question in exam is also a very important part. How you take the information, how you decipher it, and how you come to the conclusion. So one of you will take up the question, come to the answer, and you have to give me why you have chosen this answer. And then we'll discuss about it, right? Is it okay?
Yes.
Okay. So who is going to volunteering the first question?
I'll try, ma'am.
Okay, great.
A bit anxious and little nervous also. Exam is so near.
No issues. This practice helps, because whatever you do here, you will remember in the exams, right?
Like if we go wrong here, at least like in exam, we'll do right.
Yes, that's the spirit. Very good. So here we go. So this is your first question. I'm sure you will do it.
A 24-year-old woman has a history of headache before she became pregnant and was awaiting her investigation by neurologist when she became pregnant. At present, she is 12 weeks of gestation with a generalized non-throbbing headache, which is worse when she coughs and strains, and also complain of this double vision. So, and there is papilledema on clinical examination, but no other neurological signs. So this looks like a cluster headache.
Okay, fine. So why you think so?
Ma'am, because like in cluster headache, there is like normally presentation of pain, like there will be throbbing headache, and it might like the eye problems are also there. And worse during cough and strain, there is rhinorrhea also in that. But, actually, I just gave the answer. I did not think much.
You can take time, think about it.
Generalized non-throbbing was during cough and strain. Means it is like affected by increase in this intracranial pressure. Papilledema is also there.
Is it idiopathic intracranial hypertension?
Yes.
Wait, Dr. Samantha, let her think.
Okay.
Yeah. I was also thinking about that only. Like there is some intracranial pressure because these because of this papilledema. So like idiopathic intracranial hypertension should be the key.
Okay, so that's fine. The key is right. It is idiopathic intracranial hypertension, as I see many right answers in the chat box also. But then we have to clarify our doubts. So what are the features which are not in favor of the cluster headache?
Ma'am,
Papilledema,
rhinorrhea and
papillary
headache is worse
when
she coughs or strains. That's not the feature of cluster headache.
Yeah. So
First
cluster headache, yes. Yeah, please speak up, please.
First trimester of pregnancy. Most commonly idiopathic.
Okay. So that's fine. Ideal presentation of benign intracranial hypertension is the primary, young lady, obese, in first trimester, with all these features like non-throbbing headache, which get worse when she coughs or strains. There is papilledema, diplopia. So these are all features of the benign intracranial hypertension or the idiopathic intracranial hypertension.
Yes, ma'am.
So what are the ideal features for the cluster headache? There is
Cluster lacrimation, those symptoms, rhinorrhea, lacrimation.
yes, and there are no neurological signs. That
Yes,
is
ma'am.
most
Yes,
important, right? So there is no neurological signs. Pain behind the eye is there. So localized at one side may last up to 3 hours. So all these presentations, yes, periorbital pain. So these all are features of the cluster headache. So it anyways does not go with the cluster headache.
Yes,
So
ma'am.
because papilledema can anyway not be there in the cluster headache.
Yes, ma'am.
Right, so here D is the correct answer, and this is a scenario of idiopathic intracranial hypertension. So what are the features? More common in obese young women, may present for the first time in pregnancy. Pre-existing disease tends to worsen during pregnancy, and this is generalized non-throbbing headache aggravated by coughing or straining and is associated with diplopia and visual loss with papilledema. Diagnosis requires elevated CS of pressure or lumbar puncture, and management includes monitoring of the visual fields and the visual acuity because of the risk of optic nerve infarction, and therapeutic lumbar puncture or acetazolamide, which is antidiuretic, is the treatment for this particular condition. Fine. Any doubts? Is it okay?
No, ma'am. Yes,
okay.
ma'am.
Yeah. Okay. Okay, so now for the second question, who is going to volunteer? Yes, Dr. Lavanya, sure. So here is your question.
A 33-year-old woman with antiphospholipid antibody syndrome telephones a maternity assessment unit because her pregnancy test is positive. The woman has been taking edoxaban because of arterial thrombosis.
Now, what is the appropriate
Yes.
management at this step?
UPT positive, she was taking edoxaban because of arterial thrombosis. So, she needs to stop edoxaban. Antiphospholipid. And for therapeutic, she ma'am, stop edoxaban and start low molecular weight heparin twice daily.
Okay. Okay. Right. Any explanation for that?
Here she needs a therapeutic dose. So, but I'm not sure about other options, whether to check for the anti-XL10A levels.
What are the indications where we check anti-10A levels?
Yes.
What are the indications for the low molecular weight heparin where we check anti-10A levels?
Renal impairment.
Extreme of weight and BMI more than 40.
No, and for the unsection, low molecular weight heparin those. You are checking to 10A.
So,
Yes.
one is
Especially with
extremes
the
of
therapeutic
body
dose.
weight. Yes. Yeah.
Especially on therapeutic dose of low molecular weight heparin.
There is a recurrent VT.
Yes. See, for exam, you alone have to go for the paper, right? It is not going to be a group paper. So one person should remember all the 3 points. We can't have the help of the group, right?
Yes, ma'am.
So what are the 3 points where anti-10A levels are required to be measured with low molecular weight heparin? This is a very important point, often tested in exams anyway. It could be like this scenario or any scenario, but this point is tested.
In obesity, weight more than 90 kilos. That I could remember.
And renal impairment, recurrent VTI and extremes of weight. These
Yes.
are the three indications.
Yes, absolutely correct. These are the three extremes of body weight, renal impairment, and recurrent VT, right? So in these three cases, we check the anti-10A. So is this may fixes any of these fixes into any of these scenarios?
No.
No. So anyway, we are
No.
not going to measure the anti-10A.
Anti-10.
And
those
ma'am,
are-
this Edexoban, it is an like oral anticoagulant. Normally, these are not to be monitored, no? Like with like we give them these oral anticoagulants because they don't require routine monitoring.
See, in pregnancy, there is no role of these drugs.
Yes,
So no
ma'am.
need to talk about it, whether we need what or what
Yes,
not.
ma'am. In gynec.
Yes. So for here,
Yes.
when the patient is pregnant, we have to shift on to low molecular weight,
Low molecular weight.
right? And
Yes, ma'am.
no anti-10A
Yes, ma'am.
Now, what is the and of course, because she is already on anticoagulants, so it has to be therapeutic dosages and not the prophylactic dosage, right?
Yes, ma'am.
So now, what
Yes,
could be the best answer?
H.
Then it should be H, ma'am.
H. So
Yes,
your
ma'am.
first answer was correct, but then you started thinking over it, thinking, and then it's a confusion. So what are the points tested here in this question? One point tested here is what
Indications of
medication is suitable in pregnancy for anticoagulation, right? So that is
Yes,
low
ma'am.
molecular weight heparin. Second
Yes,
point
ma'am.
tested is because she is on anticoagulant, so you will choose the prophylactic dose or you will choose the therapeutic dose. So
yes,
you are choosing the therapeutic dose. Third point tested here is what is the monitoring. So monitoring is not required with the low molecular weight heparin, right? So these are
Yes,
the
ma'am.
3 points which they have tested in this one particular question, right?
Yes, ma'am.
Yes, ma'am.
Is it clear? Please
Ma'am,
mute.
one doubt.
Minute, somebody's voice. I'll mute once and then you can just sorry. I muted everybody because there was a noise, so you can unmute yourself. Yes.
Ma'am, here in the question it is written that the woman has been taking edoxaban because of arterial thrombosis. That means she has a history of arterial thrombosis. So maybe
Yes.
she has thrombosis. No, that is why she's on anticoagulant. And probably that is the reason that we should go for anti-10A monitoring later on because of recurrent VT she might be having initially.
But not mentioned that it was recurrent and venous thromboembolism.
Okay, ma'am.
So we can't say without we have any specific history because it does not say one episode. And the anticoagulants are continued for some time after the episode as well. So it does not fix into the criteria of recurrent VT, right?
Yes, ma'am.
Okay, so all clear. This question is okay. This was a typical RCOG pattern question because in RCOG also they try to mix 2-3 points and then come
Yes,
up to
ma'am.
the final question, right?
Yes, ma'am.
Everybody okay with this? So H
Yes,
is
ma'am.
the correct answer. Yes. And please remember the 3 indications for low molecular weight heparin where we measure anti-10A. This point is tested many times in the exam, right?
Yes, ma'am.
Correct answer is H. That is stop edoxaban and start low molecular weight heparin twice daily at next edoxaban dose. So you have to shift as soon as possible and no monitoring is required. And it should be therapeutic dosages. Fine? Clear?
Yes, ma'am.
yes, ma'am.
Okay, who is going to take the next? Stoppage, no time? Yes, no time. You have to shift. See, it is not sudden stoppage. You are shifting the patient from one drug to another, right? So the edoxaban is being given, when the last dose is given, after that you shift onto the low molecular weight heparin. So you are not stopping the anticoagulant, you are shifting. And there is like nothing where you can gradually decrease the dose and pick up. So it's like that. Is that fine, Dr. Saha?
Yes, ma'am.
Okay.
Ma'am, how to decide whether prophylactic dose or therapeutic dose?
Prophylactic dose is for the prophylaxis, and here the patient is already on anticoagulant. So she is already on the therapeutic part. Because edoxapan you are not using here for the prophylaxis, you are using it for the arterial thrombosis episode. So she is already on the this thing, therapeutic role. And see, whenever we continue the anticoagulant, we continue only in those patients where there is high risk. So
Yes, ma'am.
otherwise, it is not like patient is not continuously on the anticoagulant without any risk for the thrombosis. Right? So she needs the therapeutic. Like when we talk about the patients on warfarin also. So these patients are those need the higher dosages. Right?
Yes,
Okay,
ma'am.
ma'am. Thank you.
Okay, so it's going to take the next one.
I'll try, ma'am.
Yes, sure.
43-year-old woman presents 7 days after total abdominal hysterectomy because she is feeling increasingly unwell with right-sided shoulder tip pain. Temperature is 38.7, pulse is 112, BP is 123/67, respiratory rate is 15, and SpO2 is 97% on air. There is generalized abdominal tenderness, which is marked in the right upper quadrant, and bowel sounds are also reduced. Okay. I think I would go with the subphrenic abscess, ma'am.
Yes.
Okay. So what are the points in favor?
Because she's having shoulder tip pain, and it's
Referred
the
pain.
tenderness is also marked in the right upper quadrant. Bowel sounds are reduced, yes, but that can be also because of the ongoing infection. So, and temperature is raised. Respiratory rate is fine. And she's feeling increasingly unwell also. So these are all in favor of subphrenic abscess, I feel.
Okay. So everybody agrees with this? Any other answer you expect? No. That's
Can
fine.
be intra-abdominal bleeding.
Okay.
BP is fine, so I don't think it can be that.
Yes.
It is 7 days after the total abdominal hysterectomy.
Yeah.
Yeah.
So I think it's subphrenic abscess because she's presenting 7 days, like a week.
Shoulder tip pain is actually a keyword.
Yeah, diaphragmatic, they reflect on the shoulder also.
Ma'am, if we are talking about abscesses post-operatively, what should we consider the cutoff with regards to the number of days also? If you can
5
just
days
highlight.
onwards.
5 days. 5 days.
More than 5 days.
More than 5 days, fine.
Right. So basically, yes, correct. This is subphrenic abscess. What are the points in favor? One thing is unwell is the word usually RCOG used for the sepsis, right?
Fever.
Increasingly unwell, right? So this is largely a word for the sepsis. Right-sided shoulder tip pain means somewhere the diaphragm is getting irritated, right? Of course, bleeding can also irritate it, but the subphrenic abscess that is just below the diaphragm. Bleeding scenarios, the intra-abdominal bleeding scenarios are usually in the early post-operative period. Like they will give you like 6 hours, 12 hours, somewhere in between those 24 hours, right? So it is usually in that period only. So overall, if you see this, and then there is temperature. Temperature also does not go with the intra-abdominal bleeding. Rather, if the patient is bleeding too much, then she will be either cold and clammy, not the hot, not the temperature. So overall, this goes in favor of subphrenic abscess, right?
And also the right upper quadrant, no, ma'am. The abdominal tenderness in the right upper quadrant, is that hinting more towards subphrenic abscess?
Yeah, definitely, because that indicates some localized pathology.
Yes, ma'am.
Right? So the keywords here for the question are increasingly unwell, right-sided shoulder tip pain, fever is there, and abdominal tenderness marked in right upper quadrant, something consolidated there, and bowel sounds are reduced, right? So clear-cut scenario of subphrenic abscess. This question has been like repeatedly given in recalls quite a few times, and it was there in one of the recent papers as well, right?
Yes, ma'am.
Yes, ma'am. Thank you.
Welcome. So now is going to take up the next question.
Ma'am, may I?
Yeah, sure. Welcome. Yes, here is your question.
A 23-year-old woman with type 1 diabetes presents with uterine contraction at 32 weeks gestation in her first pregnancy. There is no vaginal loss and she is feeling normal fetal movements. Temperature is 37, pulse is 98, BP 116/56. Urine analysis is normal. There are 3 to 4 palpable contractions every 10 minutes. Cervix is 1 centimeter long and the os is closed. Fetal fibronectin is positive. Preterm labor in 32 weeks. 32 weeks. Nifedipine and
corticosteroids.
Also nifedipine and corticosteroids.
Okay, points in favor.
Ma'am, she's 32 weeks pregnant and the os is closed, 1 centimeter long. So we'll give nifedipine and corticosteroids for fetal lung maturity. Magnesium sulfate is not indicated as she's not going to deliver in next 24 hours. So magnesium sulfate is not to be given. D option.
Okay, fine. Everybody agrees with D, or if somebody has a different opinion? Anybody would like to comment, or shall we come to the answer? Okay, so D is the correct answer. Yes. Yeah.
Yes.
Somebody wants to say anything? Okay, so D is the correct answer. So you are absolutely correct. This is a scenario of preterm labor. And in preterm labors, we have to select from the 3 answers: tocolysis, corticosteroids, and the magnesium sulfate, right? So always first we have to look at corticosteroids, whether the corticosteroids have been given or not. Now in this question, it is not mentioned that corticosteroids have been given. So we have to give the corticosteroid. Now question mentions that the contractions are 3 to 4 palpable contractions every 10 minutes. So this is contractions are going on. So in this case, we have to give tocolysis also. Patient may progress into the labor. So we need tocolysis as well. So for tocolysis, nifedipine is the first line drug which is commonly used. So nifedipine and corticosteroids is the correct answer. Now there are 2 questions in the chat box. Why is A not the correct answer and why is G not the correct answer? Okay.
Yes, ma'am.
Okay, so let's talk about it. So why A is not the correct answer? Because MEG-self is given only if your patient is going to deliver in next 24 hours. Means
4 centimeter.
yes. Somebody's voice. So you can just mute. Yes. Okay. Thank you. So basically, first thing is that the MEG-self is given only if the patient is going to deliver within next 24 hours. That means patient should be in active labor. So always choose MEG-self in scenarios only when it is 4 centimeter and above. Otherwise also if you see 32 weeks. So MEG-self is up to what weeks?
29. 29 plus 6.
29 plus 6.
Yes. So this is not the time when we have to give the MEG-self, right? Not with the gestational age, and otherwise also it is not in active labor. So no role of MEG-self. So therefore A is not the correct answer. Now coming to D, atosiban and corticosteroids, right? Now here, patient is 1 centimeter os closed, right? So you are not at a high risk of going, like patient is not going into the preterm labor right now, right? She has some time. And secondly, nifedipine is the cost-effective medicine and it is used as a first line, although not licensed, but in most of the centers, this is considered as a first line. Atosaban has a cost. It should be given by the parenteral route, and it requires admission, requires monitoring, so not taken as a first line drug, right? In usually your exam scenarios, you will not have atosaban as the answer. Nifedipine is the most commonest answer you will find in your exam scenarios.
Yes, ma'am.
Ma'am, atosaban is licensed, ma'am.
Atosaban is licensed, yes.
But nifedipine is not.
Nifedipine is not licensed, but most of the hospital protocols go with the nifedipine as the first line.
Okay, ma'am.
Right?
Ma'am, is it like atosaban is slower than nifedipine to act as a tocolytic?
No, it is not like that, but because of the multiple factors, as I told you, cost effectiveness, admission, so it cannot be used, and it has its own monitoring also. So that is not possible for all the patients. So it is usually not used unless and until some nifedipine contraindication you see in your scenario.
Okay.
Right?
Thank you, ma'am.
Okay. So everybody agrees with D?
Yes, ma'am.
Yes, ma'am.
Yes,
Agree.
ma'am.
Everyone on
Ma'am,
the
for in utero transfer also nifedipine only will be used, right? Or atosaban we have to choose?
Nifedipine.
Nifedipine.
Oh.
Nifedipine.
Okay, thank you.
Fine. Everybody on same page? Okay.
Yes, ma'am.
Okay.
Yes, ma'am.
Yes, I agree to you. You can consider Maxwell up to 33 plus 6, but then again, it is 1 centimeter, not 4 centimeter and above, right? So I think that gives you the answer why we are not choosing Maxwell. Fine?
Yes, ma'am.